So again, almost everybody knows Professor Nodani, and this is part two of his talk around using optimization techniques and overall uncertainty management in radiation therapy planning. Omid, it's
Thank
all
you,
yours.
Sanjay. Yes. Thank you all for coming on this cold day. So what I'm planning to do, since a few of you weren't here and I think the recording wasn't very successful last time, is maybe I spend 5 to 10 minutes to review a bit what we did last time, just to give you an overview because everything else ties into it fairly well. So I gave a fairly detailed review of what was essentially published a day before we talked last time from the American Cancer Society about the new facts and statistics on both cancer treatment and the occurrence of cancer and the number of forecasted fatalities. Here are some summaries. So essentially since 2011, cancer is being identified as the leading cause of death, and the overall estimates are that about a third of them are due to our lifestyle choices and are preventable. And the probability that a person is diagnosed with cancer throughout his or her life is 44% for men and 38% for women. And lung cancer is the leading cause of cancer, and this is part of the reason why I devote a lot of my research towards lung specifically. And there are 4 treatment modalities, as we saw last time. The first one is doing nothing when the site is complicated to reach, or doing something would harm more, that the risks are higher. The second one is surgery, where essentially the cancerous portion or the tissue is taken out. The third one is chemotherapy, and the last one that we will discuss today is radiation therapy. So these last 2 are fairly similar in terms of their dynamics, as they both try to damage the cells. Now, chemotherapy does it through injecting essentially poison to the cells and causing the cell damage, and radiation therapy uses a different method that is essentially coming out from external radiation, from ionizing radiation, through the portion of the body. I hope you can see the mouse. Yes, you can. Through the portion of the body that actually contains is the volume of interest and contains the cancerous area, and is trying to essentially cause the damage. The way this damage occurs is by creating free radicals within the cell, and these free radicals generate or cause DNA damage. That again leads to either the fact that the cancer cells cannot recover from this damage and die out, or if the DNA damage is caused to the healthy tissue, then they can recover, and the patient is recovered from the damage caused by this external beam. So more recently, like about 15 years ago, they started to actually split the beam, the overall intensity, into multiple directions, and now the same amount of dose is received at the intersection of these directions, but each beam causes less damage to the healthy tissue. That's the new strategy. And obviously the optimization affects the choice of these strategies. So essentially which angle to enter with and how to distribute the dose across each beam, essentially how to modulate the intensities. I don't know why this is going back. I'm sorry. So there are 3 stages of therapy, and we discussed them last time. The first stage is in the imaging, where we collect patient data, and there are uncertainties involved. The second stage is where all the operations research and optimization occurs, where we find the best directions as well as the best intensities. And the last stage is delivery, where the final strategy, the plan, the treatment plan that was devised in the planning stage is now delivered through the rotation of the gantry as well as possible motion of the couch, and adjusting the beam intensities through this so-called multi-leaf collimator. All right? And so the uncertainties involved are numerous, as you can see, and my research has been involved with pretty much everything that is colored here. And we did some work on the dosimetric uncertainty I'm not going to discuss. And last time we discussed everything around geometry and some about misalignment. And so today I will tackle this part, the interaction with other treatment. And if we have some time, I will also tell you some new results that we have on uncertainties because of the planner. All right, so the first problem is the following. Typically, a certain amount of dose is diagnosed, is prescribed by the oncologist to be delivered to the patient, right? And because we have an interesting problem that the healthy tissue recovers a lot faster than the cancer cell propagates, we can use this difference in the dynamics and we can exploit it to the benefit of the patient. And the method used is called fractionation, and what it does is it divides this overall dose into much smaller fraction. And now the optimization task is to find the best separation, meaning in time, between these fractions and the amount of each of these fractions, the fraction size. Now for lung cancer, the typical prescription is 60 gray, and that is divided into 2 grays over 30 fractions. And each fraction is delivered on a particular day, right? So they are separated over the 5 days of the working week. That spans out about 5, sometimes 7 weeks, depending on how patient responds. Now, because of this effect, a new problem arises. That is that now we are expanding the time, right? And this extension in time leads to our next problem that we discussed last time, which is about change in geometry. And I told you that it comes at 2 different time scales. If it is of the order of seconds, then we are looking at problems, for example, with motion due to breathing. And we looked at one of our patients where we have the 2 lungs. For those of you who haven't seen this sketch, so this is the actual CT of the patient. These are the 2 lungs. Then we have the rib cage. These are the white areas on the outside. And here we have the spine. And this is the location of the tumor that is delineated by the treatment planner or radiation physicist. And now we plan the best strategy for this particular site, meaning we find the best angles as well as the best intensities. And now the beam is on for about 20 minutes at each fraction. And as you've seen, this 20 minutes means that every 5 to 6 seconds, the tumor goes in and outside the beam, causing 2 problems. The first one is we don't deliver enough radiation to the cancer cells, not causing the healing or the treatment that we would like to achieve. And the second problem is we are causing damage to the healthy tissue, which probably or potentially can lead to secondary cancer. We have also done some work on misalignment, namely when the patient is not laying down every day on the exact same spot. So we have a certain strategy for a particular coordinate system, but now the patient is slightly misaligned. The other problem that may arise is the gantry that I mentioned to you moves essentially coplanar to the patient, but the actual location of it can be disturbed every time due to misalignment or misgauging and so on. And lastly, the actual beam intensities that need to be delivered by the leaflets, by adjusting the leaflets, that is subject to uncertainties that because they move fairly fast and they may not deliver exactly the same dose intensity distribution that we want. The other problem that can arise is the change in shape, as I mentioned to you. So these treatments are, so these treatments are typically, as I mentioned, take about 5 to 7 weeks. And our hope is that by the end of the treatment, the tumor is gone or significantly smaller than before. However, the original plan that we have, it will be repeated over and over. And as you can imagine, the assumption about fractionation is that we can repeat, meaning that the assumptions don't change, right? In this case, clinically, we hope that these assumptions change, right? We hope that the tumor vanishes. And I showed you our strategy, how we do that. So essentially, we take clinical data about the size of the tumor, and we know that for different patients, the shrinkage, the regression, goes with different rates, right? So you have slow regression, or you have very fast shrinking tumors. And now we offer a database or a way for the clinician to make a judgment how our current patient matches the previous data that were collected, and cast a probability distribution over these possible scenarios, and then do a stochastic program to come up with the best matching strategy to deliver a dose distribution for a shrinking tumor. One of the nice aspects about this approach is that it doesn't really require any additional imaging, because that comes at a cost, both monetary as well as additional dose to the patient, and it's not necessary. However, if we have a chance to take a midway CT scan, for example, then we can tie down the risks or the likelihood of success even better than before. And just briefly, the sketch of it is that we essentially adjust the beam over time to the shrinking target. And I showed you the clinical outcome and why we believe that they are successful. So now this is the new stuff for this stuff. The other thing that may happen whenever we stretch the time is that the biology of the tissue changes over time. What do we mean with that? Again, it depends on time. So if the time is very short, of the order of seconds, it's way too short for the biology to adjust during this short time period. If it is longer, of the order of hours and days, well, typically most of these treatments are concurrent with chemotherapy. Chemotherapy, as you know, actually changes the consistency of the tissue, of the cells. And that matters very much to how the reaction or how the interaction with the ionizing radiation works out with tumor cells. And the second aspect is the radiosensitivity, which is the response of the tissue to a fixed amount of dose changes over time. Right? So let's take a closer look at these two. So first of all, chemotherapy, what it does with respect to radiation is that it changes the proximity of the location we are looking at to blood capillaries. Right? Why is that important? Because blood transports oxygen. The more oxygen we have, you will see in a second, the more damage we can cause with the same amount of radiation. And the second reason why chemotherapy interacts very much with radiation is that a lot of these agents, these chemotherapeutical agents, have an additional drug for in order to sensitize or enhance the response of the tissue to radiation. It's called radiosensitizing drugs that is typically mixed into it. Now, what does it do is that it enhances the damage of the same amount of radiation to the tissue. And positron electron positive emission tomography scans have shown that we can actually see a huge change in terms of oxygenations within the cell as time progresses, right? And it's measurable. Now, in general, as I mentioned, we know that the more oxygen there is in the cell, the more we can cause damage with the same amount of dose, right? The nice thing about it is, if we can cause more damage, that means we can lower the dose to achieve the same amount of clinical objective, right? And that spares the healthy tissue significantly. And so Michael Ferris and Felker a while ago suggested to use these daily dose uncertainties, and they casted a stochastic program to adjust for this daily planning, and they came up with some very nice rules of thumb to apply it. Now they need to be recomputed over and over, and their approach was computationally very restricted, and they had to settle to heuristics. So my angle, or our angle, to this same problem is the following. So I'm essentially taking this problem, reformulating it from the oxygen point of view. What do we know? We know that the response of the radiation changes in time, right? So that's the first assumption. And we know that once the patient is admitted to the hospital, the cancer cells are hypoxic. That means they really lack oxygen. And over time, they're exposed to oxygen because the pathway to the nearest capillaries are shortened. So what we use is the very standard method that describes the progression of DNA damage in the cells. It's called the linear quadratic model, and essentially it is based on the stem cell principle that also applies to cancer cells because of two reasons. First of all, the cancer cells can proliferate limitlessly, and they can also replicate themselves, very much like stem cells. And so the yield of a lethal lesion has a linear component that depends on the dose, and it has a quadratic component that depends on the dose, right? And it has a negative factor for proliferation that works against the yield, right? So that's proliferation of cancer cells throughout the body. Now, this process is a Poisson process. So what we can do is we can write down the survival probability as a Poissonian, and this is for if we have only one single dose that we deliver. If we fractionate, as I mentioned, and we deliver equal amount of dose, all we have to do is take the exponent n, which is the number of fractions, into the survival probability. Any questions so far? Right. So this is classic linear quadratic model that is used in radiobiology. And I showed you this figure last time. This leads to the following, that if we deliver, for example, 20 grays of those in one shot, we cause 10 to the minus 8, or the survival fraction for normal tissue goes down to 10 to the minus 8. If we divide it into 10 fractions, it increases up to almost 10 to the minus 3. So we can improve 5 degrees of order of magnitude and improve or exhaust or exploit this difference dynamics between normal tissue and cancer cells.
This is still equal dose.
This is equal dose, exactly. This is all equal dose, and we will in a bit relax the constraint of equality between each fraction size. All right. So again, we have this dynamic as I showed you before. Now we allow oxygenation to change in time. So if oxygenation changes in time, that means that the same ionizing radiation, the same amount of dose, creates more free radicals. As a result, we will have more DNA damage, and so on. Right? So that magnifies the effect, which allows us to reduce the dose. Right? So that's the hope. So the way we use this aspect is the following. So we call this, or it is called oxygen effect, and we use the oxygen dependent modification factor, OMF, that was introduced in 2008 by Titz and Geray to compute the biological aspect of it with respect to how much damage a certain dose causes. Now we want to keep the damage constant and change the dose. Right? So essentially the actual effective dose is only a fraction of the delivered dose. So this is the physical dose, the D, and the effective dose is a fraction of it. So OMF is between 0 and 1, and it's a function of the partial pressure of the oxygen that is in the cells.
So when you say damage constant, you mean relative to the volume of previous?
Correct. Right.
So the ratio of the volume pre and post.
Exactly, right? Or if you count the number of cells, it would be the survival probability. Like how many cells did you have before, how many do you have now? Right? You can also compute the volume if you assume similar size cells, right? So now the nice thing is, in the past couple of years, we have now methods to compute or to actually observe this partial pressure of oxygen, right, through PET scans in vivo. So what we do is we actually just plug in this factor into our survival probability. And because we want to exploit the fractionation effect, I'm going to relax the fact that these doses are equal for each fraction, right? So we don't have equal dose anymore, and what we have to do now, and this OMF also changes in time. So far the assumption was that we have one OMF factor and it stays constant, but no, we know that the oxygenation changes in time. We can actually measure it. So why don't we adapt the model accordingly. So now the total survival probability is the product of single fraction survival probability, right? Because the D changes and the OMF changes, right? And each of them is computed this way, all right? So this is what, and then we took this into the clinic. We looked at patients at the Indiana University Cancer Center, and we basically measured these the factors. So we have this coefficient alpha for the linear term. We have OMF for each fraction. We have beta for a quadratic term, and we have this gamma for the proliferation that we need to know. Typically, the size of n, the number of fractions, is I don't want to tap into political issues, but essentially it's predetermined because of the scheduling of hospitals quite often, right? Or because of, I don't know, higher reasons. But optimizing this is one of my goals, but
Could be different for different patients.
it could be, absolutely. Right. But right now it's, lung cancer has this amount of fractions for each clinic, and they just do the standard protocol.
Right. So right now, you say could be political, right? They're not changing it at a particular center. So for a patient, irrespective of the scheduling issues, they're going to do a certain number of fractions.
Correct.
That can change from center to center, but
Exactly. Within the center,
Within the
or let's say
center.
within the clinician or oncologist, that's a constant almost. Right? So the numbers that we collected based on the patient were that the ratio of alpha over beta for tumor cells were 10, and for normal tissue was 3.7. The proliferation factor is really hard to measure. You have to essentially grow cells and observe them. That's beyond my scope. So we basically took the value from the literature, and we observed the OMF over time, as I mentioned. And so what we know, though, is the following, because, again, this is very expensive to measure, right? What we know for sure, and this is essentially what came out of this exercise in the hospital, was that when the patient is admitted and the first set of scans are taken, the OMF is 0.2, which means only 20% of the same amount of radiation is effective 20%. Right? And we know that on the last day, hopefully, the tumors are oxic, fully oxygenated, and behave exactly like normal cells with respect to radiation. Right? So essentially, we can cause the same amount of damage to the tumor as we could do to normal tissue. Here, we only cause 20% of the damage to the, yes?
because of the surface area. So the tumor that's inside the clump
Right. There are a
is
lot
not
more
getting
radio
enough because
sensitive.
you're not getting enough capillaries going
That's
to.
right. There are more radio resistant.
Okay, you want
It's
that
not.
needle to
I see,
disclose.
oh, the pressure.
Right.
Yeah.
So the blood's flowing to the surface, and that's where it's getting absorbed.
Right. And then so because you don't have the oxygen inside the tumor cells, they're not oxygenated as well as the healthy tissues. And you need the oxygen to create the free radicals that cause the DNA damage.
Okay, no, fine. But, maybe on the side. So the PET CT, if I remember correctly, sort of maybe the opposite principle, right? Shows greater oxygenation of
Is
the areas that get lit up.
right.
Maybe less, maybe that way.
So yeah, but with PET, you can determine which part of the overall volume has more oxygen, which part has less
Right.
volume.
But it's really the less oxygenation part that's because cancer cells are also dividing rapidly, right? So
That's right.
they are consuming more oxygen.
Exactly.
as
So they're
rapidly
consuming
dividing.
more oxygen and they're not receiving enough oxygen. So there are two aspects that add up to become radio resistant.
I see.
Right? Exactly. All right. So this is the current, or this was the outcome, or this is the outcome essentially if you would do it in the clinic the way it's done. So this is delivering 60 grays at 2 gray per fraction for 30 fractions. Right? And so for the tumor cells, we cause roughly 10 to the minus 6 damage. The same 2 grays to the neighboring healthy tissue causes roughly 10 to the minus 8 damage, right? Which is, at least to me at first, extremely surprising, meaning you cause 30 times more damage to healthy tissue than to tumor cells because the tumor cells are radioresistive. Okay, so what we did was the following. We said, apparently it is okay to cause this much damage in the clinic, right, to the normal tissue. So what we do is we call this our constraint. So we are willing to allow this much damage. How can we optimize the dose per fraction such that the damage is controlled the same way, but the damage to the tumor cells is improved significantly? Right? And at first, based on clinician suggestion, we assumed a linear change in OMF in time. We start at 0.2, we end up at 1 on the last day of delivery. And this is how much better you can do. And the improvement is roughly 25 times damage to the tumor now at the same amount of damage to the healthy tissue than if you would just do the uniform dose per fraction over time. Right? Now, while this result is great, and I would suggest to implement, or we are working on convincing them to implement it in clinic, besides, again, some scheduling issue because it's easier to always do the same thing every day. I'm also very aware of the fact that this improvement only works if everything goes well, meaning if the OMF really changes linearly in time. Right? This is under that assumption, and we don't really know that for sure throughout the time. So the way we want to model this issue is the following. Again, what I know is that this OMF changes not because time is elapsing, but because the dose is accumulating over time. More and more dose is delivered, and it adds up. But the evolution between these 2 points is uncertain. So these are the two assumptions, essentially. And so if we look at this OMF factor as a function of dose, what we really know are these 2 fixed points, right? We know that on day 1 at 0 dose is 20%, and after we delivered all the dose, hopefully the patient is healed or well treated, and the OMF is back to 1, which means the cancer cells behave the same way as the healthy tissue with respect to the radiation. Right? What we don't know is how we get from this point to the upper right-hand corner. And what we do is we actually just parameterize that. We say there are possible paths going through. One of them is the linear path, and we can parameterize this progression in time. And what we have now is we have what I call dose impact exponent, this lambda, that allows me to parameterize what I don't know, or the uncertainty is embedded in the lambda. Right? And with that, we can now go back to the drawing board and recast the problem. So now the robust problem is as following. And let me start with the constraint first. So the OMF to the target, so this is the planning target volume, to the tumor, changes as a function of accumulated dose divided by the prescribed dose. Right? And the way this change happened has an exponent lambda, as I just mentioned to you. On day 1, we start at 20%, and once this is 1, it should be adding up to 1.0. Right? So this is how we parameterize it. And the uncertainty is hidden in this exponent lambda. That's why there is a tilde over it. Right? And for now, we assume that this uncertainty
is the function you have assumed to parameterize.
Say again?
And the form of the function you have assumed to parameterize. Right?
Is uncertain as well. Absolutely,
right.
Yes.
So, for example, just go back to your figure before. You had the concave function up down in the beginning, and it's all fine up until you get the linear growth, where it's a huge kink. So it's going to be either concave function that you drew, or it's maybe an S-shaped function that actually works in the beginning and then sort of begins to. I'm just looking at 2 extreme points and trying to fit the, the model in between.
Right. Absolutely. Yeah. So and I get to that actually. So the actual form of this function is also debatable or is uncertain. Absolutely, yes. But for now, this is the most general version of writing it down. So the second constraint is that for all organs at risk, for all the healthy normal tissue, this OMF stays constant in time and is always 1. And the third one is if we add up all the dose that we deliver, it should never exceed the prescribed dose, because then we cause other problems. And the last one is obviously dose is non-negative. And so the objective is minimizing, with respect to the dose, the maximum of the survival rate, right? And so this is this robust approach. We are essentially minimizing the worst case outcome, or the worst case parameterization, the worst possible lambda that we may have with respect to that over time. And the last constraint that is very important is that we don't cause more damage that clinicians are willing to take, as I just showed you, with respect to normal tissue, right? So we have this damage that we are willing to take, and that's a constant. And so for all the organs at risk, meaning the normal tissue, it should not exceed what would happen with uniform dose per fraction.
You really need equality in the second equation of equations?
No. So
No,
DI
the
is the
fine.
same as that.
The first one is fine. I mean, the second one. We have lambda pairs. The second such of the equality.
That's
first
right.
equality.
That doesn't change. The OMF to the healthy tissue
But you
doesn't
need
change.
equality.
That's right.
You do.
You do.
Okay.
All right. And so, back to, let me go back one second. I'm sorry. Where is it? So to Sanjay's, so we assume that we don't know this shape very well, right? So we want to basically use a robust approach that is independent or not so much dependent of the way we actually parameterize it, right? And that's why we went back, that's why we want to use the robust optimization method that we developed a while ago that does the same thing. So it's a min-max, and J is now the cost, and let's say this is the decision variable, and this is the error that this decision variable may encounter, and the error resides in a ellipsoidal in this case. So say if we have the point P, if we have the decision P, we can have the maximizers somewhere on this ellipsoidal on the outer bound. And if we can find a direction D that allows me to take a step, that allows me to update my decision such that if I take this decision, then the maximizer is less than if I don't, then I improved my worst case cost, right? So, and then I'm doing the minimization on the outside. And we showed that this D would reside within a cone, this shaded, this darker shaded cone, that is essentially normal to the cone of all bad neighbors, of all the maximizers, right? And as long as this D makes an angle that is greater than 90 degrees to all the bad neighbors, to all the delta P stars, then we can improve as long as there is no maximum, no local maximum within the ellipsoidal. Right? So in a nutshell, in order to maximize that angle between our descent direction and all the bad neighbors, we have to solve a second order cone problem that is essentially a minimization of a negative number, essentially maximization of the angle D makes with all the bad neighbors around it. And so once we solve these SOCPs, we actually can determine the descent direction D, we take a step along this descent direction, and we have excluded all these maximizers. Now this method is fairly generic, and we adapted it slightly to this problem that we were discussing. And let me show you the result. So back to the uncertain trajectories that I showed you earlier. In the nominal case, we assume a lambda of 1, and in the worst case or test case, we assume a deviation by 0.5. Right? And earlier I showed you this result. So if we do just a conventional uniform dose, 2 grays per fraction, we would get 10 to the minus 6 damage. So we normalize everything with respect to that. If we deviate by 0.5 with respect to lambda, our survival fraction degrades or worsens by a factor of 20. If we do the adaptive, you have a question?
Yeah.
If you do the adaptive that I showed you, we can actually do 25 times better, and even if we deviate, we are still doing 11 times better. Now, in the last case, the robust case, we don't do as well as before. We are doing only 20 times better, right? However, this is known in the literature as the price of robustness. So you pay a little bit, but then in the worst case scenario, now we are doing 18 times better than before, which was 11. And this also applies to the other exponents. All right? So with this, I want to conclude that I hope I convinced you that this robust methods allows us to go beyond convex problems. And if we do adaptation, we can improve a lot. But it is very important that they only are valid and useful and powerful whenever all the assumptions are realized. Right? Whenever the assumptions of adaptation is not realized, it can go very bad. And lastly, we use this robust evolution-based radiotherapy to not just work around this problem, the changes in time, but actually harness them. We can now make them do beneficial stuff for us with respect to geometric and biological changes. I'd like to thank my colleagues Mark Langer and Indra Das at Indiana University and Joe Secco and Thomas Wortfeld at Mass General for graciously providing us all the patient data. And obviously, without my students, things would be a lot harder. So this is Arka, Dawei, and Jocelyn. Some of you may have met them. Shall I talk 5 minutes about other stuff?
Yeah.
Where's Jocelyn?
She is downstairs right next to Jonathan.
No, but where is she now?
Oh, good question. I don't know.
Yeah, I was hoping some of your friends here, right?
I'm assuming the cold weather.
Yeah, that's true.
Good question.
Is Arka here or is he?
Arka is traveling. He'll
He's
be back in a
traveling.
few days. Yeah. So I'm planning to do a few algorithmic works, but let me talk about the radiation part. So the first thing, or one of the things that I'm already working on, is how to make these decisions more data-based. And I showed you a few teasers last time. And if we have time, I will also discuss a bit about what I think about engineering health and how to induce recovery and not just do something and hope it works. So the first part, I mentioned to you that once we have these plans, we essentially, through a mathematical program, we come up with a set of beam angles and how the intensity should be modulated from each of these beam directions. And that data file essentially is shipped to the delivery site, which is typically this joint, and now this plan is supposed to be delivered. Now, during this process of finding the best locations and so on, what typically happens is that the medical personnel has to make a lot of decisions on their own, right? So they come up with objectives, and they try to meet these objectives. Typically, they don't work out. So they have to relax some constraint. Which constraint is relaxed is a very subjective matter. And at the end of the day, they come up with, if they are very good, they come up with competing plans that are presented to the oncologist, and the oncologist makes a visual inspection. All these plans, they satisfy norms, they satisfy standards, and the oncologist makes a decision. And this decision is very personal, very subjective, and because of that, not reproducible. So this is a quality metric for a dose distribution. For those of you who weren't here last time and are not familiar, let me repeat this quick. So this is it's called dose volume histogram, and it's a cumulative histogram that measures what portion of the volume receives how much dose. So for a target, you would like 100% of the target volume receiving exactly the prescribed dose, nothing more, right? If you're to the right, there's an overdose, and if you're on the left, it's considered an underdose, right? So this is the goal. Obviously hard to meet, but that's how we want to measure quality. So we had a head and neck case, and we gave it to 7 different treatment planners, right? And that was the teaser from last time. And they were all asked to do their very best, and they did. Right? And I want you to just look at the oval-shaped area. The dashed line is the 100% line. right? That's the ideal line. And as you can see, the 7 plans barely overlap, right? They all go through this area, which is the standard that they have to meet. But anything beyond that doesn't work out. And in fact, 2 of them don't even go through it. All right? So this is the discrepancy that you may encounter if you allow 7 different people, or sometimes the same person on different days, right? Use the same software on the same patient, and the choice is done visually. That's the problem, right? So they all meet criteria, the standard international criteria, this ICRU 83, and but which one is better? Right? And even if you ask multiple oncologists, they may disagree on which one is the winner. And so my goal was to try to bring in a little bit more reproducibility into this whole process. First of all, overcoming the issue with visual inspection, having data that tells us there is some metric which one is better than the other. And second of all, if the treatment planner does it tomorrow, he or she would get exactly the same results, right? If this is the gold standard. So what I did was we collected a lot of data, and what I will show you in a bit is the following. So if this is the center line, this is what we want to achieve. We computed the median of many, many different plans, because these are, again, those distributions. And we computed the minimum dose, so whatever is to the left, and we computed the maximum dose, whatever is to the right, right? And that's shown here. So these are over 800 patients. This is the median when we divide the planned dose, so which is about to be delivered to the patient, by the dose that was prescribed by the oncologist, right? So ideally, the median should be right on 1, and ideally, the minimum dose should no more than 10% be off of the 1, and the maximum dose should also not deviate more than 1. Right? This is what we had for these 800 patients. Right? And as you can see, quite often, let me use the mouse, quite often we have patients that are receiving minimum doses that are way beyond the 10% line, right? And quite often we have maximal doses that are way beyond. So this is all overdose, right? And it's all over the place, right? So there are cases where essentially the minimum dose is almost 0, as you can see, for example, here, like with this case. Or the maximum dose is 40% off, right? Potentially causing secondary cancer and so on. So what we did was we actually resorted all these patients, and we saw that there is an interesting trend. The interesting part is that there are institutions that are obviously all over the map, and there are other institutions that are consistently meeting the criteria, right? So yes, there is uncertainty in the process itself, but the uncertainty is fairly well controlled dependent on the institutions, right? And for example, institution 2 and institution 5 seem to be very reliable, versus 1, 3, and 4 are all over the place. And again, the assumption is everybody did their very best. So these are real patients, and these are data that were actually administered and delivered to the patients.
Do you know the characteristics of these institutions, or maybe that's the next slide?
I
this is very
do-
few still, but
So that part I cannot reveal.
no,
That is the thing.
characteristics meaning academic versus
These are all
non-academic.
hospitals.
These are all,
These are all leading
but some
cancer
are
hospitals.
connected with an academic program, others are not.
I didn't dig into that question. Can I answer that ad hoc?
It's very few, I know. It's almost impossible.
I don't think
to,
we can. Yeah. So what we did was the following. We said, okay, institution 2 apparently is doing well, right? Let's dig a little bit deeper and see what they do, and how can we learn from them to come up with a plan, to come up, if you wish, with a program, with a strategy to keep them in control, to keep institution 1 in control. So again, all of these, they actually meet the protocols. None of them violated the protocols, right? but they are completely off of being ideal. So this is for institution 2. Again, I want you to think, so this is a 3D map, but this is my dose volume histogram, right? So this is at 100%, goes down here, and drops at 100% dose, right? So this is the curve that you saw earlier. I hope you can, everybody following, right? So this is on the 2D layer is the DVH, and on the color map is essentially the frequencies, the likelihood of those 100 patients that we had here.
So there are 100 patients across the y-axis, x being 1.1.
So no, so I'm sorry. So this is where's my mouse? Here. So this is the volume,
This is from the 2D,
right? So this is the volume. This is the dose,
I see. Sorry.
right?
Yeah.
And on the height, you see the frequency, the probability of meeting that particular dose. All right. So let me run this around, and then you can see a little bit better. So we see that there are areas that's around 50%. Areas of high confidence and high agreement. And for example, out here, you see high disagreement, actually. This is at high dose, high volume areas, right? The top where they are supposed to intersect. There you see a high higher disagreement, even at this top institution. So what we did was we fused all this data together, and now we have a way that if a new plan comes in, we can say with this likelihood, your plan is actually meeting a top institution or not, right? So if this is the gold standard, you can always go back and measure your plan versus that plan. And we are actually doing the same thing for single physicians. So if a physician has been delivered the dose in a certain way over the past 10 years, now it's possible to compare a new plan versus all the past decisions that person has taken, right? So you can bring consistency within the decisions of single planners, single decisions within the hospital, nationwide, and so on. So you can scale it up or down. And yeah, we actually developed an iPhone and iPad app that allows you to right away compare on the fly, take a snapshot, and have a graphical, but more importantly, a data-supported decision-making tool to do that. So this last part is more, because this is unpublished work right now, as more on sketching the idea. So what I would like to do is the following. I know how the tumor, or we have a good understanding of how to respond to a changing tumor in size. And we have also a good understanding, as I showed you, how to adjust the strategies if the biology is changing, if the response is changing. First of all, we actually merge them together and basically have all the spatial temporal changes combined to each other as to how to devise a strategy over time that matches all these different evolutions. But all of this is based on taking a decision, watching a certain reaction to happen, and now we have a way to forecast the reactions, and you take the decision based on those forecasts. I want to essentially reverse this action and say, since I know this, I can actually go backwards and cause a certain progression, right? Since I know how the radiation will change over time, why don't I make changes that we really like? And so here is the sketch. Let's say this is our tumor, and this is in this case it's the spinal cord, but say this is the most important organ that I want to protect. And the tumor is right adjacent to it. The way it's done currently is we deliver the same amount of dose uniformly across the tumor over time, and now the tumor is shrinking. Right? What we can do is, instead of doing that, what we can say, this part is the critical area, right? Essentially, we could give a lot of dose to this section, right? I use the mouse so the recording can see that as well. So this section, apparently, is the area we could increase the dose significantly. There we can escalate the dose. Here, we want to be very careful. Now, being very careful means lower dose or extended time. right? And so what we can do is, instead of just having one uniform beam over time doing the same thing, we can actually re-strategize the following fashion. We can start off with a very narrow beam, low dose, to essentially make the shrinkage happen away from the critical organ. Once we have clearance, we can boost the dose and improve the quality of life for the patient, so that the person doesn't need to come back very often to the hospital, right? So we achieve the, if you wish, almost better sparing of the critical organ. It was a lot faster at a lower dose in the proximity of the critical organ and at a higher dose somewhere else. So we essentially, that's how I want to use this word, we are inducing this recovery, or we are engineering the process of tackling the tumor. And that's it. Thank you. Questions?
So just the last slide, which is really intriguing, probably not taught in the literature. So you.
It's not published yet, so.
I mean, I'm talking about the last slide.
I know, yeah.
Right. If you have 3D shapes, which are probably more, and they're irregular,
Mm-hmm.
so some are covering
Mhm.
more. Can you have a handle on that
It's-
as much? Because
so-
you're just sort of pushing the envelope out
Right.
from
So
OAR to
everything I showed here is essentially a 2D image of a 3D object,
3D
right?
object.
So this, what I showed you, is actually a real patient. This is a real CT. And the sketch is from only one angle,
one angle.
right? But we have up to 7 angles usually allows most clinics, let you take, because it's a matter of
CT.
time. No. The number of angles, it takes time to go from one angle, move next angle, and so on.
Twice
So most clinics, they restrict you to 5 to 7 angles
for the gantry.
for a gantry to move, right? So if you allow within this number of angles, then you can very well actually modulate the delivery to the 3D object, and that has been shown in the literature.
I see. So you're trying to do this every time. So you're modulating the angles every time you are actually delivering.
Right. So they're essentially, it's the same gantry. It goes to one angle, it
Mhm.
delivers, then it moves to the next one.
But it's not. So again, the impression I got was, do it over time. Sort of on day 1, you go from a certain angle.
Correct.
And,
Yes,
and
right.
on day 2, a
Right.
different
Wait,
angle. Which
You
is
could do
different from
that.
saying that you do it all on the same day.
Right. So
5
you
different
can
angles on the same day.
exactly.
They're delivering the same dose from all angles, right?
No. There are different. So the dose from different angles are different, and also the way the dose is distributed from each angle is different.
So does that mean a different setup for the patient? Like give the option for day to day, or the patient on the gantry is the same?
The patient on the gantry is typically the same. Yeah. I mean, there are some works to do a non-coplanar, so you move the, but they are very, very difficult to manage, and most people don't really like that.
So are the people locked in? Let's say if somebody's getting a radiation to their lung.
Right.
So head, for example, you lock in the head.
Yes. So
Not
for
the
head,
lung.
there is like a mask. They actually lock you.
How about the,
Not
the
really,
lung?
no. But it used to, so back in the days, what they used to do is they used to actually increase the oxygen, so they would have a mask.
Mhm.
They would hyperventilate the patient so that the motion of the lung is a lot calmer.
Mhm.
It turned out that a lot of people actually start to panic because that's not
Because
the
of
way
the-
they usually breathe, and then you have coughing and all this other stuff. So a lot of hospitals don't do that anymore. What they do though is some more modern hospitals, they have a plastic box that they place on the stomach, and they watch it with a CCD camera, how the stomach is moving, and based on that, they're essentially tracking the breathing motion. And then they have the models to map it back about how the tumor is actually moving.
Well, let's say, just an extreme example, right? Somebody coughs. Too bad for that.
Too bad,
for that.
exactly.
For that.
That's right.
For that few seconds.
That's right. So they're essentially
But versus when somebody coughs and moves a little bit
right.
at the
Yeah.
same time.
So
But
what
these
the,
are, and these are long sessions, right?
20
Long
minutes typically,
minutes.
yeah. That's the order. So usually they have a little tattoo, like a cross, and there's a laser from the top that aligns the patient.
Right.
And again, it really depends on the clinic, but those that I have observed, there is a person watching that. So there's a camera making sure and so on.
So
But
that's my question, like with the tattoo, it's not for a certain, like you don't have to change that if you're changing.
no. Yeah.
It's changing the diameter. So does the I assume the alignment does not change because these are physical devices. It's very hard for them to actually move from one configuration to another.
Be more specific.
So,
what do you mean?
so 5 times, right? Saying, well, let this thing change 5 times over 20 minutes.
Oh no, that
the
can change very
configuration.
easy. The actual beam, you mean?
Mhm.
No, that's very easy. So inside the beam, let me see.
So what prevents you
Can
from
I
doing more than
just
5?
I just stopped the recording because
What prevents